I just want to say a heartfelt thank you to the organizers of this symposium, the ILC Foundation, as well as the Spontaneous Intracranial Hypotension Group or Spinal CSF Leak Organization of Canada for putting together this fantastic symposium. And I also want to thank all the speakers we have today. Everyone's volunteered their time to be here on a Saturday to speak to us. So thank you so much for your time and for your expertise. So without further ado, let's begin with the first topic today. And we'll be speaking about spontaneous intracranial hypotension as one of the focuses of the conference today, as you all know. And in my portion of the talk, we'll be speaking mostly on the clinical characteristics because we have our other experts coming up after me that will speak to the other elements of SiH. So I will focus mostly on the clinical characteristics. And as mentioned, I'm a clinical associate professor at the University of Calgary with a subspecialty in headache, and I do have a special interest in SiH. So I'm happy to present this topic to you today. So let's begin with just some basics. So what is SiH, or spontaneous intracranial hypotension? So this is a condition where a leak or a hole basically occurs within the dura, and the dura is the thick covering layer that goes all around the brain and down into the spine, covering the spinal cord. And underneath that flows fluid, or cerebral spinal fluid, CSF for short. And sometimes what can happen is that spontaneously, not due to any other reasons, a leak can occur in that area. And once a leak occurs, then fluid can start to leak out and cause the constellation of symptoms that we see as SiH. And the reason we call it spontaneous is that it's not because of other things that have happened, for example, surgical intervention that may have caused a leak to occur during the surgery itself, or it's not because there was a lumbar puncture, for example, or a spinal tap that caused the leak to occur, but really it's happened spontaneously without any other cause that we know of, other than in some cases trauma, and we'll get into that a little bit more. The other important thing is that when we say spontaneous intracranial hypotension, typically, we're referring to spinal CSF leaks. So these are leaks that occur at the level of the spine itself and not elsewhere. Whereas CSF leaks can actually occur elsewhere too, for example, in the brain or the cranium or within the sinus areas in the cavities of the brain. They can occur as well. And typically they have a different presentation and it's a different type of condition. So we won't be addressing that today. But today we'll be talking about SiH related to spinal CSF leaks. So as time has gone on, this condition has become definitely better recognized over time than in the past. But still, it's an area where many patients, the public, and even healthcare practitioners still don't know too much about. It's still considered a relatively rare condition. But in the neurology world, where I work, as well as some of the other areas from the experts that you'll hear, it's something that we do see not too uncommonly, in fact. But it is certainly an area where we need to do more education and create more awareness. The other thing is that, for other reasons, SiH is also difficult to diagnose, and we'll get into some of that today, but it can overlap with other conditions. Sometimes because it's been going on for a long time, it may not have some of those classic features that we tend to look for in our history. Sometimes the imaging can be normal, and that does make it much more difficult as well. And then even when it's diagnosed, it can also be difficult to treat because we need some experts in the area to recognize it, to treat it appropriately. And not all centers, as you'll hear today, have access to the expertise that they need. So that is another challenge that we face, especially in Canada. And Dr. Peng will be speaking to some of that as well today. So in terms of the epidemiology, or how common is this? So we don't actually have that information accurately. We don't really know for sure how common is this condition because there really hasn't been a lot of long-term prospective types of studies or randomized controlled trials. So it's really just an estimate at this point in time. And the estimate is that it's probably somewhere around 5 per 100,000 people have this condition. And the onset of symptoms typically tends to be in the 4th to 5th decades of life. So it can certainly be sooner, and it's been even recognized in children, and it can be even in the elderly. But that's typically the time peak is around the 4th to 5th decade of life, typically around the age of 40 years as the most common time period. And it does affect women more than men. So approximately 1.5 times more women are affected by this condition as compared to men. So in terms of the cause, as we talked about, it's caused by spontaneous spinal CSF leaks, so not related to injury from, for example, surgery that someone has had or from a lumbar puncture that they've had, but really it happens spontaneously. And in many cases, we never really know the exact cause of it, but we feel that in many cases it's multifactorial, which means that it can be from multiple different causes. Many patients will already have some fragility or underlying structural abnormalities at that level, whether that be from, for example, connective tissue conditions or degenerative disc disease of the cervical spine in particular, or potentially, they've had some of this underlying, but then they've had even a minor trauma that can elicit it. But interestingly, trauma is not common in many cases of spinal CSF leak, or if it is, it's quite mild trauma. So sometimes even something such as whiplash injury, or lifting something heavy, or turning or twisting can be sufficient sometimes to cause a spinal CSF leak. And in general, it seems that about a third of patients have some history of trauma, but many may not have a history of trauma. As we talked about, connective tissue disorders are very important as well. In particular, inherited connective tissue disorders can play a role in the development of CSF leaks. And it's really because the dura itself is a connective tissue as well. So we can really think of that as part of the spectrum of different types of tissues that can get affected in connective tissue conditions. Particularly Marfan syndrome, Ehlers-Danlos type 2, and autosomal dominant polycystic kidney disease are the most common types of connective tissue disorders that we see related to spinal CSF leaks. And interestingly, there have also been reports of familial SiH, so first degree family relatives having SiH, but it is quite a rare condition, and typically there isn't a positive family history. The other thing that we talked about as the potential underlying cause that can lead to spinal CSF leaks is abnormal bones, essentially. So osseous spinal pathology, most commonly, this will be degenerative disc disease, and osteophytes are basically sharp areas of bone that can pierce the dura and cause a hole to occur. Occasionally, this can be congenital, so patients can be born with various abnormalities such as bony spurs, dural holes or rents, meningeal diverticuli, which are basically outpouchings of the tissue that surrounds some of the spinal nerves, and even sometimes absence of the dura. So there can be cases where they may not be dura in certain parts of the spine as well. In terms of our current understanding of what actually happens that underlies this condition, what we think is that the symptoms are actually related to loss of intracranial CSF volume rather than strictly a reduction in pressure. So even though the name spontaneous intracranial hypotension meaning low pressure, has been given to this condition, in many cases, actually, patients exhibit normal opening pressure. But one of the things that potentially may happen is that there might be a change from a patient's baseline pressure down to a lower level, but that could still be within normal. So that may be one reason to explain it. But the second reason is that we really think it's a loss of intracranial CSF volume rather than strictly a reduction in that pressure. And we think that this happens through a few different mechanisms. So one is that leaks can occur secondary to dural weakness in the area of a nerve root sleeve. So that basically where the nerve roots are exiting at the level of the spine, there can be those meningeal diverticuli or outpouchings like we talked about. And if that's an area of weakness, a tear or a hole can occur at that level and cause leakage of the fluid. There can also be ventral dural tears, and that's basically the undersurface of the spine area or the anterior portion where there's often degenerative disc disease like those osteophytes or sharp pieces of bone like we were talking about that can cause a dural hole or a rent to occur. And disc herniations are a common cause of that along with the degenerative disc disease. And then thirdly, a more commonly recognized entity recently is a CSF venous fistula. So basically this is where there's a direct connection between the CSF pathways as well as the veins around that area of the spine. And that sometimes can be difficult to recognize with just standard imaging, and specialized imaging might be required for that. But that's in a third sort of mechanism by which we think this volume loss can happen in the spine. In terms of the actual diagnostic criteria, or how we diagnose this condition, the ICHD, which is the International Classification of Headache Disorders, 3rd edition, which is the most recent edition, has set out some guidelines in terms of how we actually diagnose this condition. But as you will see through my talk, as well as through other experts today, that this criteria, unfortunately, is quite specific. So if these findings are found, it certainly means a patient does have spontaneous intracranial hypotension, but they're not necessarily sensitive, so that if patients don't necessarily fall into one of these categories, they may not be diagnosed as SiH. But we do certainly think that there are patients that, for example, may not have that low CSF opening pressure like we talked about, or they may not necessarily show signs of CSF leak on their imaging, in particular MRI, which is kind of the standard. But they may demonstrate in other types of imaging, or it may be found at the time of surgery. So just to keep in mind that even though this criteria has been laid out by the International Classification of Headache Disorders, it's not necessarily fully sensitive to pick up all cases of SiH. But the criteria are that with this, that it's low CSF pressure, less than 60 millimeters of CSF, or evidence of CSF leakage on imaging, and that the headache has developed in temporal relation to the low CSF pressure or leakage, or led to its discovery, and of course, not better accounted for by any other diagnosis. In regards to the clinical presentation of SiH, so the prototypical, or really the most common classic manifestation of SiH, is that there's an orthostatic headache, which means that basically patients will have a headache when they're upright, and they feel much better when they lay down, and that's what we refer to as orthostatic. Some people will also call that positional, but positional would not be as specific, because sometimes positional can actually have the opposite pattern. So typically orthostatic is the best way to describe it, where things are much worse when a patient is upright, much better when they lay down. And this worsening of headache when a patient becomes upright can occur within seconds to minutes of taking an upright position, but it can actually be much more delayed than that as well. So it can even be hours later. Sometimes patients will have no headache, for example, for several hours, and then describe that they have a headache in the afternoon or even evening time frame. So it can be quite delayed as well. It's more consistent, though, that the headache improves within 30 minutes or so of laying down. So again, that's not in every case, but most patients will say that within minutes, particularly within 30 minutes or so, that they'll start to see some improvement in their headache. And after several hours, it can be much better. And patients often will say that first thing in the morning before they get up from bed, they often feel much, much better, sometimes even having no headache at all. Typically, the headache will be holocephalic or diffuse, meaning that it involves the whole head and kind of equal on the right and left side, but it may be more localized to that, to one region of the head, for example, more on the right or more on the left, or it could be more asymmetric. It could be more occipital or in the neck as well, so it can vary quite a bit. And the quality of the headache can vary as well. So some patients will describe a pressure sensation, some will describe an ache, some will describe pounding or throbbing. So it can vary quite a bit in terms of its actual quality as well. In terms of the onset of the headache, in the majority of patients, this is gradual, or what we call subacute. So it's often over days to weeks. But sometimes it can present very suddenly and even be considered what we call a thunderclap headache. So it can come on within seconds and be very severe. That's a relatively rare presentation of this condition, but it can still happen. And the severity can vary as well. So for some patients, it can be mild, and other patients, it can be moderate or severe. And we actually don't know the exact cause of the headache. It hasn't been fully elucidated, but what we think happens is that there's at least some partial relationship to the downward displacement of the brain due to the loss of CSF buoyancy. So when there is a leakage occurring, and that fluid that normally surrounds the brain and keeps that brain buoyant, once that volume is lost, then that buoyancy can be lost, and therefore it can pull and put traction on a lot of the pain-sensitive structures. The other thing that we think happens as well is that there's dilatation of the pain-sensitive intracranial venous structure. So the veins and the venous systems in the brain, which are pain-sensitive, become dilated, and that in itself could potentially cause some of the pain that we see as well with this condition. In regards to the orthostatic headache, one of the important things is that it can actually become less prominent or even disappear over time. So think it's important to go back and ask a patient kind of how the headache first presented, especially, if the patient is being seen months or years later, which can often be the case. It's really important to go back and say, when the headache first started, did it have that orthostatic quality to it where it would be much worse upright and better laying down, because that can change over time. Rarely we see the reverse pattern as well, where patients can be better upright and worse laying down. That actually would be quite rare, and we don't really know exactly why that happens, but that has been described in the literature. And there's also patients that don't have a postural component to their headache. So, they may, right from the start, they may say, no, I don't really see much of a difference between laying down and being upright. So we really have to have a high degree of suspicion in those patients, and really, hinder on some of the other symptoms, and look at the imaging as well to try and confirm that diagnosis. And then there can be other headache patterns as well. So patients can have exertional headache, for example, which means that they'll have a headache when they're, for example, doing exertional activities such as physical activity, coughing, straining, sneezing, things like that, which cause increased exertion. As we talked about, the headache can be much later in the day, such as evening time frame, or what we talked about, paradoxical as well, where they may even have that opposite pattern, but that's quite rare. So I think it's important to really think about spontaneous intracranial hypotension, not only in those classical presentations where patients can have that orthostatic headache, but in a patient that comes in with a new headache that persists, that doesn't fit any other diagnostic category very well, that may not respond to the typical treatments, and may also fit this pattern of headache that we call new daily persistent headache, which is a headache that just starts one day and basically just persists and continues, and we don't really have any other good explanation for it. So really do think about SiH in those presentations, and not just in the classic orthostatic presentation. Some of the other things that we can see with SiH, in addition to the headache, are other types of symptoms such as posterior neck pain or stiffness. Patients can sometimes have nausea or vomiting, or even a little bit of sensitivity to light or sound. About a quarter or so of patients may have other symptoms too. For example, they may say that they have an echoing sound in their ear, or they feel like their ears are plugged, or that they're underwater. They may have various types of ringing in the ears or tinnitus. They may have a disturbed sense of balance. And then rarely patients can have some other things as well. So sometimes they can have visual blurring, deficits in their visual field. So they may have patchy vision, or pieces of vision that they can't see through very well. They may have double vision. There can be facial numbness or numbness elsewhere in the body, sometimes weakness, although that's quite rare. And sometimes even Parkinsonian types of symptoms. So they can have slowing or stiffness. They can have trouble with their balance or gait, like we talked about. And cases of cognitive impairment or dementia have even been described with this condition as well. So there can actually be a broad array of other symptoms also to keep in mind with SiH. In regards to evaluating this condition, so I won't go into any of these in detail because we have experts that will be speaking to this in terms of the radiology, as well as some of the treatment modalities. But just as a broad overview to let you know that typically once we suspect this condition, we often start with brain imaging. Sometimes patients will have had a CT of the brain done. CT often isn't very helpful, but it often does rule out other causes of headache potentially. So it is sometimes done. But really the mainstay of evaluation as a first step is an MRI of the brain, and that needs to be done with gadolinium or enhancement because we will be looking for signs of pachymeningeal enhancement, for example. And again, I won't get into that in detail because Dr. Gray, our neuroradiologist that will be speaking to us today, will certainly, I'm sure, get into some of that. As well as an MRI of the spine, which is quite helpful. And those are typically the first lines of evaluation or intervention. And then there can be other more interventional types of studies that we would do if we're more suspicious of a CSF leak or if we're trying to localize the leak. So the initial MRI is done to help confirm the diagnosis, and sometimes that can be negative. And then if we want to localize the leak or go further, then we would go on to some of these other investigations that we would do. And then there are specialized investigations that not all centers do, but for example, you'll see there at the bottom, digital subtraction imaging. So this is a specialized technique that's done to look specifically for fast leaks, for example, CSF venous fistulas, et cetera. And unfortunately, it's not available at all centers, but it is a nice modality to have available. And then we can also look at some other things. So for example, the CSF profile, and I have a slide on that, but it's not often very helpful. And actually it's not done very commonly anymore. So we used to do CSF analysis more commonly and also measure the opening pressure. But as I've mentioned to you, many patients can have normal opening pressure. So we're not finding it all that helpful. But if it is low, it can be helpful to confirm the diagnosis. So typically we're looking at opening pressure that's less than 60 millimeters of water. There can be a lymphocytic pleocytosis, meaning that there can be increased white blood cell counts of the lymphocyte type, but it may perfectly be normal as well. And sometimes we can also see increased protein, but again, the protein can often be normal as well. And there can also be xanthochromia, which is just the breakdown products of red blood cells that we tend to see, because there can be tearing of small veins or arteries. And so the blood products can sometimes be evident in the CSF as well. In terms of treatment, again, I won't get into this in very much detail because we have, again, a number of our experts today speaking about some of the therapies, particularly blood patches, other types of injections such as fibrin glue, and then surgical repair as well. But again, just to provide you with an overview, that typically once we suspect this diagnosis, we would start with some conservative treatment. So initially bed rest as well as hydration, oral hydration. So we recommend patients drink lots of fluids because we feel that there's a loss of that volume. Caffeine can be quite helpful for patients symptomatically. So often patients will drink some coffee. Sometimes we use medications such as steroids just as a bridge or a transitional type of therapy to help patients get through kind of a headache exacerbation, but we don't have very good studies on steroids, such as randomized controlled trials to let us know that they can be helpful. So we really just use it as a temporizing measure. And then really the mainstay of treatment for this condition is the epidural blood patch. So basically that's where a patient's own blood is taken and injected into the spinal area, and that can be done at multiple levels, such as the lumbar, thoracic, or cervical area, to try and really seal that leak. And again, I won't get into that in too much detail, but I do have one slide. And then, once blood patches are done, if they're not successful, or if a patient can't have a blood patch for one reason or another, then really surgical intervention is kind of the final resort for the treatment. So in regards to the epidural blood patch, in some patients, this can actually provide instant relief. And, part of that may be just the volume replacement. But we think that there is other mechanisms by which blood patches can have their effect. So potentially they can provide a dural tamponade. Blood patches could potentially restrict CSF flow within the epidural space. And that might lead to decreased CSF absorption over time, which means that there's more volume around. And we think that long-term, probably there's some change in the dural stiffness or resistance as well. So the dura becomes a little bit tougher over time to try and mitigate, future CSF leaks or prevent them from happening again. But many patients don't respond, or they may respond only partially. So if that's the case, we typically recommend that blood patches be repeated. We also recommend higher volume because there is some evidence in the literature that higher volume blood patches can be more effective. And then of course, if we know the site of the leak, then targeted blood patches, so going right at the target of where that leak is, also tends to be more successful. Sometimes we don't have the luxury of knowing that, and we have to do what's called blind or lumbar, thoracic level blood patches, just kind of estimating where we think might be the best place to go. But of course, if we know the target, then that's always the best to go and try and do a targeted blood patch. I just wanted to also talk a little bit about some of the recommendations that are out there for connective tissue disorders, particularly, especially given that this can be a condition where we do tend to see spinal CSF leaks. And there's not a lot of literature out there, but a nice study with the Cedars-Sinai group, so Dr. Shivink's group in Cedars-Sinai at Los Angeles, was done in 2013 that looked at 50 patients that were diagnosed with spontaneous intracranial hypotension. And of these patients, 9 of them had heritable connective tissue disorders, such as Marfan syndrome or Ehlers-Danlos syndrome, and others among that as well. And of these 9, 7 of the patients had SiH as their first manifestation or first presentation of their illness. So it's really important to note that these patients really got that diagnosis afterwards when they were seen by a specialist. after they first presented with the SiH. So we really do have to be careful that we're screening patients and asking them questions to look for the potential of connective tissue disorders, even if SiH might be their first presentation. And that's really what the authors of the study suggested, is that patients with SiH should be screened for connective tissue disorders, as well as vascular abnormalities. And we'll talk about that in a second as well. And then, of course, if there's concerns with the initial screen that the patient has, then they should be referred on, particularly to a medical geneticist that can then more formally diagnose them with their particular connective tissue disorder. In regards to recommendations for vascular disorders, so we do know as well that vascular abnormalities tend to occur with a higher frequency in patients that have SiH compared to control patients. And again, one of the studies that was done looking at this in 2011 showed that intracranial aneurysms occur in 9% of patients with SiH, as compared to 1% of patients that have no known SiH. So really, if we consider control patients as having 1% where they present with intracranial aneurysms, this goes up to 9% in patients that have SiH. So definitely an increased risk there. So patients with SiH should also have some intracranial vascular imaging at some point throughout their assessment and treatment, typically with a CT angiogram or MR angiogram, just to potentially look for this. And patients that have established connective tissue disorder, so those that have things like Marfan syndrome, for example, should be screened further with an MR angiogram of the neck, chest, and abdomen, as well as pelvis, actually, because they're at risk of having large arterial aneurysms, not only in the brain, but other areas as well. So it's really important that we do think about this when we're seeing patients with SiH. One of the questionnaires that's been developed, and this has actually been by Dr. Reinstein's group in Cedars-Sinai. This was actually part of the study that I mentioned, where it was found that patients can present with SiH initially and then go on to have a diagnosis of connective tissue disorders. So this is just a questionnaire that was adapted with permission from Dr. Reinstein's group. Dr. Reinstein's a medical geneticist at Cedars-Sinai. And basically, these are some of the common questions that will be helpful to ask patients when they do present to see potentially whether they might be at higher risk of a connective tissue disorder. And I won't go through line by line, but basically you can see there's some general questions to ask. For example, looking at things like height and weight and body habitus, ethnicity, family history, and then looking at pregnancy, development, and neonatal history as well, because those can be important in terms of some of the risk factors associated with connective tissue disorders. And then we have signs for skin hyperextensibility and fragility as well, of course. So looking at things like elasticity, bruising, transparent skin, uterine prolapse in female patients, previous surgical complications, spontaneous pneumothorax, and other things. And then also to go on and look at joint hypermobility and complications of that, such as joint dislocations, hypermobility of the joints, chronic joint and limb pain, scoliosis, etc. And there is something called the Baton score, and I have a slide on that to show you what that is, but that can also be quite helpful in determining if patients have joint hypermobility. And then also cardiovascular history, like we talked about. So if the patient has history of aortic or other types of arterial aneurysms, dissections or rupture, valvular disease, etc. And then in addition, the other things to look at would be cranial facial features, ophthalmoplegic or ophthalmic features. And then this is the Baton score that I was referring to. So it's basically a simple system to quantify joint laxity and hypermobility. It uses a 9-point scale or system to try and quantify that. And basically the higher the score, the more lax the joint is. And basically scores above 6 are considered to be in the hypermobile range. And as you can see, there's different maneuvers there that are shown. So it's a quick, simple way that can be done in a clinic setting to try and assess whether a patient has laxity or hypermobility. And then also to go on just to discuss some recommendations for cardiac disorders. So like we talked about, patients can be at higher risk for cardiac conditions as well. So an echocardiogram is suggested to assess for valvular disease, particularly mitral valve prolapse seems to be one of the most common things that's seen. Also dilatation of the aortic root can be seen as well. And in another study in 2014, the rate of cardiovascular abnormalities that was detected, and this is for the same cohort of patients that were seen at Cedars-Sinai, the 50 patients that we talked about, it was found that 9 out of 50 patients, or 18%, did have some sort of cardiovascular abnormality. 6 of these showed aortic root dilatation and 3 showed valvular heart disease. And only 2 out of the 9 patients had an underlying connective tissue disorder in this cardiovascular cohort that they looked at, which indicates that cardiovascular pathology can occur even in patients that don't have a known connective tissue disorder. So it can be even outside of the context of that. So we really do recommend that patients, again, at some point throughout their assessment, have echocardiography done in order to look for any potential cardiac disorders as well. Now, I just wanted to lay out this algorithm or diagram because it's one that we use at our clinics. Of course, there's different ways to look at SiH presentation and workup, but this is one that our group in Calgary has found to be quite helpful. And I have another one that looks at a typical SiH as well. But basically, typical SiH would be patients that have the general classic presentation where, clinically it is highly suspected. And if that's the case, we typically recommend conservative measures and then going on for the patient to have an MRI of the brain. If conservative measures don't lead to any improvement, and the patient then shows signs both clinically and on MRI, but even if the MRI is normal, but we highly suspect it clinically, then we would suggest that the patient go on to have initially non-targeted blood patches. If that's successful, that's great, and the patient can be followed. But if it's not successful, then up to 2 or 3 attempts can be given to that. But if the patient doesn't have success with that, then we would suggest to go on to do more investigations. And if a patient hasn't yet been seen by neurology or at a specific center that specializes in SiH, that might be a good time to refer the patient. But from there, then we would suggest that a patient first has a non-invasive MR myelogram, and that's basically the MRI of a spine that's heavily T2 weighted. So it's a specialized technique where it's more sensitive to pick up CSF, but it's non-invasive in that there's no injection required with that. And some centers will do that. And that's a nice test to do first because it is non-invasive. It doesn't involve any radiation. And if it provides some clues or answers, that's very helpful. Then patients might be able to go on to have localized blood patching, etc. But if that's not the case, then we would recommend going on to a CT myelogram because then there is radiation involved and it is an invasive type of test. There's an injection, spinal injection required for that. And depending on if there is fluid, extradural fluid seen on the MRI, then one can determine whether it should be a dynamic CT myelogram or conventional CT myelogram. Dynamic means that the patient is basically being injected in the scanner and then the scan is being watched as that's happening. So it's essentially live. So if there's extradural fluid collection on the MRI, typically a dynamic CT myelogram would be more helpful. If there isn't one, then conventional CT myelogram. And then either with that or if necessary beyond that, then there's the digital subtraction myelogram like I talked about, which is typically what we do if there's fast or high flow leaks suspected, if there's ventral leaks, or if there's CSF venous fistulas. And some of the centers will combine a CT myelogram together with a digital subtraction myelogram like we do often in Calgary. So if that leads to the leak being localized, that's fantastic. Then, targeted approaches could be trials either with blood patches, fibrin glue, or then to go on to surgery if required. But unfortunately, if the leak is not localized, it still provides a dilemma in terms of what to do. Some of the centers, particularly in the US, maybe will try to go on to do some targeted patches or even surgical exploration. Some centers would not do that. But I think one of the other important things is to ensure that if all the imaging is negative and the headache is atypical, which is basically what we're dealing with here, is that you kind of do reconsider the diagnosis as well. So atypical SiH here would be patients that maybe don't present in the classic way. Maybe they have a headache that's persistent but doesn't have some of those orthostatic features. So if that's the case, it is important to make sure that there is some confirmation of that diagnosis somehow, either with imaging. And that's why if the MRI is normal, you may not necessarily go on to do blood patches right off the bat. But if it is showing signs, certainly you could do that. So if it's a normal scan and the features of the headache are atypical, we would suggest that patient has more investigations to help confirm that diagnosis of CSF leak. But otherwise, the workup would be quite similar. And again, this is just one way that we look at the workup in Calgary, but different centers will have different approaches to it as well. And then just lastly, to discuss the prognosis of this condition. So with this condition, it's really hard to know how patients will do because there's such a variability of presentations and course. But typically, kind of looking at all comers, recurrence tends to be in about 10% of patients, and that seems to be actually regardless of treatment. But patients that have had successful treatment hopefully will have longer periods of remission and may not have recurrence. But it seems overall it's about 10%. And then some of the good prognostic factors. So if patients do have classic presentations and classic MRI changes, then obviously it's much more easy to diagnose the condition. Also, if they have a focal CSF leak where targeted therapies such as blood patches or surgery can be done, then that also leads to a better prognosis. But poor prognostic factors are essentially the opposite. So if a patient has a normal initial MRI, it may not become recognized right away that they have this condition. Or if they have diffuse multi-level CSF leaks, then it can be quite difficult as well to treat that condition also. So with that, I wanted to thank you so much for your attention. And I have my references listed here as well. And I'm happy to take any questions at this point. Thank you so much.